adrenergic neurons such as norepinephrine or adrenaline, or epinephrine. We have the synthesis, which is the production. We have the storage, the release, the receptor binding, and the removal or degradation of this neurotransmitter from the synaptic gap. But our main focus of today is basically the drugs. So we are not going to be talking about the process of formation. We're going to talk about this later. Now, adrenal receptors are basically G protein coupled receptors, and we have two types, like I've already explained. We have alpha and we have beta. And we also have a specialized class, which is the dopamine receptor. It's a distinct family of receptor from alpha and beta receptor that shows a strong response for dopamine from D1, D2, D3, D4 to D5. Those are its subtypes. Now, this is what I'm talking about. We have alpha 1, alpha 2, beta 1, beta 2, beta 3, and we have dopamine from D1, D2. D1 and D2 are the most common, but from D3 to D5, yeah, not really that common. Now, I said these particular receptors, they are located in different organs of the body. If your normal physiological system is to release norepinephrine, it's going to act on this receptor to trigger a biological response. Alpha 1 is located in the blood vessel. If norepinephrine, the fight or flight hormone, right, during sympathetic response is being triggered, it will bind to the blood vessel, constrict the blood vessel, and increase blood pressure. That's increased blood flow. Alpha 2 is found in the pancreas, in the GIT. So at some certain parts of the brain, alpha 2 can also be stimulated to modulate sympathetic response. We have beta 1. Beta 1 being found in the hearts, especially. We have it also found in the kidney, in the ureter, and in the stomach. But in the heart, beta 1 receptors are being stimulated to cause an increased heart rates. That's what we call increased contraction of the heart, increased heart rates. While it stimulates the lungs to dilate the bronchioles, the bronchi walls, what we call bronchodilation. That is because the normal stress response is that it wants to dilate the walls of the lungs so that more air can flow. And we have the adipose tissue, which is where beta 3 receptors are located. Of course, adipose tissue, gluconeogenesis, lipolysis, doing that stress, fight or flight response. So adrenaline is going to bind to beta receptors, B3, at the adipose tissue. Now, these are where they are localized. That shows that if you're looking at the pharmacology of adrenergic drugs, you're looking at this, how to influence the physiology of the basic physiological pathway of these organs, from blood vessel, from heart, from lungs. So if a patient is hypertensive, we know that we are to target beta 1 receptor, which is the heart, and alpha 1 receptor, which is the blood vessel, to reduce hypertension. Moving over to the next slide, there you can see, I'm not going to go much details into this, but the type of protein coupled receptors that they are, some are inhibitory, some are stimulatory. You can see the locations for alpha 1, alpha 2, beta 1, beta 2, beta 3, D1, and D2. And here you're going to look at it. What are the functions that it inhibits, or that they exhibit rather. We have vasoconstriction for alpha 1, which leads to an increased peripheral resistance and increased blood pressure. Mydriasis, that's dilation of the pupils. And we have increased closure of the internal sphincter of the bladder. But an important key factor is vasoconstriction. Alpha 2, we have inhibition of norepinephrine release. So there's a modulation of sympathetic pathway from the brain itself, from the CNS. That's for alpha 2. For beta, which is found in the heart, we have tachycardia, increased heart rate. We have increased myocardial contractility. For beta 2, which can lead to vasodilation, relaxation of the blood vessel at the superficial level, at the skeletal muscle and the likes. But an important one is the bronchodilation, relaxing of the walls of the lungs so that more air can flow. Those are the adrenal receptors. Now I've spoken about adrenergic receptors and the type of adrenergic receptors, the location of where they are found in the body, and what are their physiological function, what do they do when they are stimulated. Let's look at the drugs that can either stimulate this adrenergic receptor for a therapeutic effect or those that can block the adrenergic receptor. I'll talk about adrenergic agonists. They are drugs that can potentiate or stimulate adrenergic receptor such as alpha 1, alpha 2, beta 1, beta 2, beta 3 for a therapeutic effect. Now, of course, you cannot talk about adrenergic agonists or adrenergic drugs or sympathomimetic amines without talking about the catecholamine. They are called catecholamine because they contain the catechol hydroxyl group. They include epinephrine, norepinephrine, isoproterenol, and dopamine. I explained the last time, as you can see from this whiteboard, that catecholamine is catechol plus amine. They include noradrenaline, adrenaline, dopamine, and isoproterenol, which is synthetically made. And I already explained that alpha receptor, alpha 1 blood vessel, alpha 2 majorly in the CNS, beta 1 heart, beta 2 lungs, beta 3 adipose tissue. And I spoke about the non-catecholamine, which are the phenylephrine, amphetamine, and epinephrine. So I'm just going to be skimming through all I spoke about. So catecholamine are the examples above. They share high potency. They are really potent. They can stimulate the alpha and beta receptor. They can be degraded or metabolized by the COMT or MOA enzymes. The COMT is for catechol all methyl transferase, while the MOA is for monoamine oxidase. Because epinephrine, norepinephrine, isoproterenol, and dopamine, they are monoamines. So MAO is monoamine oxidase. We have monoamine A, we have monoamine B. So they can be easily degraded. And they have poor penetration into the CNS. They are polar and they do not readily penetrate in the CNS. While for the non-catecholamine, they are compound lacking the catechol hydroxyl group. An example are phenylephrine, ephedrine, and amphetamine. They have prolonged action because they cannot be degraded or inactivated by the COMT enzyme. They are poor substrate for monoamine oxidase, and they are lipid soluble. That means they can penetrate into the CNS. That is why amphetamine is a drug of abuse. They can penetrate into the CNS and can act as a stimulant. Now, talking about adrenergic drugs, can be classified into adrenergic agonists or adrenergic antagonists based on what I've shared on my screen there. Adrenergic drugs can be classified into two broad classes: adrenergic agonists, which are the sympathomimetics. So from the word mimetics, that means they mimic sympathetic response, while adrenergic blockers or adrenergic antagonists, don't forget that antagonist is to antagonize, to oppose, or we can call them sympatholytics. Now we'll be looking at adrenergic agonists. We have the direct acting, those that act on the receptors itself. They bind to the receptors and they stimulate the receptors. We have the mixed acting and we have the indirect acting. Let's move on to the next slide. If you are going to look closely, the direct acting can be further divided into selective, non-selective. So what do we mean by selective? Don't forget that I've explained selectivity, and I said selectivity is when a particular drugs have this high affinity for a particular receptor. It selectively binds to this receptor, and this receptor is located at certain organs. So it is selective to a particular organ. It does not affect other organs. For example, alpha 1 is found on the blood, alpha 2 is found in the CNS. If a drug is only selected to alpha 1, it's going to bind only to the walls of the blood vessel. If it is non-selective, it is binding to all alpha receptors. It is binding to all subtypes. If it is selective, it is binding to only one subtype at a particular organ. If it is non-selective, it is generalized, binding to all subtypes, depending on where they are being located. So we have mixed acting. those that can act on both alpha and beta receptors. And then we have the indirect acting. They can modulate the COMT enzyme or prevent the reuptake or act as releasing agents. Adrenergic agonist, which is the beta adrenergic agonist. Don't forget that we have beta 1 and beta 2 and also beta 3, but our main focus here is beta 1 and beta 2 in particular. Beta 1 is found on the heart. When they are being stimulated, of course, they will increase heart rate. Beta 2 is found in the lungs. They can also cause vasodilation, but when they are stimulated when beta 2 is stimulated in the lungs, they will cause the relaxation of the bronchial walls or the walls of the lungs. Now, we have certain drugs that can act either selectively on a particular beta receptor or mixed or non-selective. For the first one, isoproterenol, it will act on both beta 1 and beta 2 receptor, which makes it a beta 1 and beta 2 agonist. It is used for bradycardia because when these two are being stimulated, they can increase blood pressure. So when a patient is having severe hypertension, we use isoproterenol. But they have side effects such as palpitation, heart palpitation, headaches. It can also lead to tachycardia because you are increasing the heart rate. It can lead to tachycardia and flushing also. We have dobutamine. Dobutamine is beta 1 agonist and alpha 1 agonist. This is a mixed kind of agonist. It can be used for alpha 1 agonist or alpha 1 antagonist. Basically, it's for congestive heart failure and it is for short term. It is an alkaloid that is derived from plants, very, very toxic. It can cause heart attack, it can lead to arrhythmias. We have albuterol, which is a beta 2 agonist. For patients with asthma or bronchospasm, meaning their bronchial walls is closing in, is tightening, we can use albuterol inhaler to relieve the bronchial walls. Like if you want to relax the bronchial wall, not to cause bronchodilation. So it is used for bronchospasm. Some of the side effects include anxiety, headache, and dry mouth. We have salmeterol, which is long acting. So albuterol is short acting or short term. Salmeterol is long acting. It's also a beta 2 agonist used for bronchospasm or COPD, chronic obstructive pulmonary disease, right, of the lungs. Side effects include upper respiratory tract infections, inflammation because of the relaxation and production of inflammatory mediators. We have formoterol, which is also for bronchospasm and the likes. But what is the mechanism of action of adrenergic agonists in particular? Direct acting acts directly on the drug, alpha or beta, to produce effects similar to those occurring with natural stimulation of the sympathetic nerve. Indirect agonists, they act indirectly by blocking the reuptake of norepinephrine, causing the release of norepinephrine, that's blocking the reuptake, increasing the release of norepinephrine, or inhibiting the degradation of norepinephrine. So they act indirectly in allowing this neurotransmitter, adrenergic neurotransmitter, norepinephrine, to play out. We have the mix acting. They have the capacity to both stimulate adrenoreceptor and to release norepinephrine from adrenergic neurons. So now, looking at the direct acting, we have epinephrine. I'm going to stop at the direct acting for today and we'll continue later. We have epinephrine. Epinephrine interacts with both alpha and beta receptor. At low doses, they have better effects on the vascular system, but at high doses, they are more prone to bind to alpha receptors to cause vasoconstriction. So you know that epinephrine acts on basically the key player organs when it comes to sympathetic response, which is the CVS and respiratory system. So its action on the CVS is that it strengthens the contractility of myocardium. That's positive ionotropic effect. It increases the contraction, the force of contraction of the heart, increases the contraction and increases the heart rates. So we have, it causes positive ionotropic effect, positive chronotropic effects. Those are the beta 1 action because it binds to beta 1. For beta 2, it causes bronchodilation. So it acts on the bronchial smooth muscle and relaxes them. It can also act on adipose tissue, on other peripheral organs to cause lipolysis on beta 3 receptors, hyperglycemia, and the likes. What do we use epinephrine for? The first one is for anaphylactic shock. When a patient is undergoing anaphylactic shock, it is characterized by respiratory conditions such as bronchospasm. That means the bronchial walls will be tightened due to this production of inflammatory response. Don't forget that the bronchial or the bronchus, they're made up of smooth muscle. And this when inflammatory mediators are being released, or if there's a shock, it can cause inflammation in the lungs and the lungs can narrow down. So we use epinephrine for respiratory condition to cause bronchodilation. We also give it in case of glaucoma to reduce intraocular pressure because epinephrine causes mydriasis, that's dilation of the pupil. We also use it for cardiac arrest and for local anesthesia in some cases. Some of the adverse effects include fear, tremor, tension, and cardiac arrhythmias. We have norepinephrine. Norepinephrine is a neurotransmitter or neuromediator of adrenergic neurons. In therapeutic dose, it can bind to both alpha and beta receptors. Some of the cardiovascular effects include vasoconstriction and baroreceptor reflex. That means it detects whether there's a rise or reduction of blood pressure in the walls of the blood vessel. There are baroreceptors there, so it can trigger the release of norepinephrine. Some of the therapeutic use is treatment of shock because it increases vascular resistance and therefore increases blood pressure. We have the synthetically produced one, which is the isoproterenol. Isoproterenol binds to beta 1 and beta 2. It is non-selective. That is, it can bind to both 1 and 2. And that's very, very dangerous because imagine the heart rate being increased, the lungs being relaxed for a protracted period of time. So it is non-selective and it is being withdrawn because of its side effects. It has insignificant action on alpha receptors and can cause increase in cardiac output, force of contraction, increase in heart rate, has serious side effects. We also have dopamine receptors that can also activate alpha and beta receptors as well as dopaminergic receptors. So this one has negligible effects, but is worth looking at the dopaminergic receptors and how they influence sympathetic response. So you can look at the slide and look at some of the details there. Now we have dobutamine, which is also synthetically produced. They act on beta 1 agonists. They increase cardiac rates and cardiac output, and they are used for congestive heart failure. We have oxylmetazoline, which is directly acting alpha 1 and alpha 2 agonists. So we are looking at all the adrenergic agonists in particular, right? They can be used as nasal spray decongestants because what this does is that, as is written here, particular area is going to decrease the congestion. So there's not going to be much production of mucus because mucus is fluid coming out of the blood. They are exudates. They are fluid from the blood, alongside bacteria, debris, and the likes. That's oxymetazoline is going to constrict the blood at the nasal mucosa. That's why it is used as a nasal spray decongestant to decrease congestion. We have a very popular one, phenylephrine. Phenylephrine is a direct acting adrenergic drug that binds to alpha 1 receptor, and alpha 1 is blood. It's found in the blood vessel. It is a potent vasoconstrictor. It is used to treat hypertension and can also be used as a nasal decongestant when applied topically. Also effective for mydriasis in case of glaucoma. We have clonidine, which is an alpha 2 agonist that is used in the treatment of hypertension. Can also be used to minimize the symptoms of withdrawal therapy in patients that are addicted to opiates, benzodiazepine, and the likes. Now, clonidine acts presynaptically in the brain to decrease sympathetic flow. Don't forget that I said that some alpha receptors are inhibitory, so they're going to inhibit sympathetic flow. That is because there ought to be a balance in sympathetic and parasympathetic flow. That modulates sympathetic flow, and clonidine will act on alpha 2 to stimulate it to decrease the sympathetic flow. We have albuterol, I've already explained it, which are the SABs or SABAs rather, short-acting beta-2 agonists used as the bronchodilators, and we have the long-acting, and we have the terbutaline, which is a off-label uterine relaxant. So we are going to explain that in endocrine pharmacology, just for you to just look at the slide and read what is there. We have salmeterol or fumeterol. They are the long-acting beta agonists. They are selective. Don't forget that these are selective, right? They can be used as a single, not really recommended as a monotherapy. They can be used in conjunction with other drugs, such as corticosteroid. They can reduce the inflammation in patients with asthma or COPD, which is chronic obstructive pulmonary disease. And we have the indirect acting adrenergic agonists, which are the amphetamines. You can look at what amphetamines does, the uses of amphetamines. We have the tyramine, and we have the cocaine. And we have the mixed action, which is the ephedrine and pseudoephedrine. They can bind to both alpha or beta receptors. And some of their functions, what they are used for, but they are not necessarily used because of their serious side effects. So all the summary of everything I'm going to talk about is actually what is here. It's actually what is here. Adrenergic agonists divided into direct acting, mixed acting, indirect acting. Direct acting further divided into selective and non-selective. We have the alpha, alpha 2. Just know some of the common examples. Some of the common examples here are the phenylephrine for alpha 1. They are the clonidine. I'm going to attach a table, a more clearer table that's going to distinguish between these. But I feel like this is what gives a clear distinction. We also have indirect acting, the releasing agent, the uptake inhibitors, monoamine oxidase inhibitors, and the COMT inhibitors. And we have the non-selective. So a clinical question would go that if a patient is having asthma and is hypertensive, you are not going to give beta 2, or rather, you are not going to give some particular drugs that are non-selective. You're going to give those that are selective. Because imagine it's binding to beta 1 and beta 2. You're not going to give isoproterenol because it's going to bind to 1 and 2, beta 1 and beta 2. It's going to affect the heart. You're going to give a selective drug, which is beta 2 agonist, such as albuterol for asthma. And if the patient is hypertensive, you can also give a beta blocker, which is propranolol. That's we are going to discuss adrenergic antagonists in our next class. So I'm going to stop here for now. We have discussed adrenergic agonists. We have looked at some of the examples, what they do, their clinical indication, what they are indicated for, some of their side effects. You can think them up based on the fact that they are stimulating the sympathetic nervous system. You can think some of their side effects.